The phrase preterm birth hides several different outcomes. A trial can ask whether birth occurred before 37 weeks. It can ask whether birth occurred before 34 weeks. It can ask about 33, 32, 30, or 28 weeks. It can restrict the outcome to spontaneous preterm birth. It can include medically indicated deliveries. It can measure neonatal morbidity. It can measure time from diagnosis to delivery. It can measure mean gestational age at birth. These are not interchangeable. Before 37 weeks is the broad boundary. It tells us whether the pregnancy reached term, but it groups together late preterm birth and extreme preterm birth. From the perspective of neonatal risk, that is a very wide container. Before 34 weeks is closer to the severe preterm question. Many progesterone trials and meta-analyses emphasize it because neonatal morbidity becomes more consequential as gestational age falls. Before 28 weeks asks an even sharper question. Did we prevent birth in the extreme preterm zone? The absolute number of events may be small, so studies can be underpowered, but clinically, the endpoint is powerful. Now ask a different question. What if a treatment does not prevent preterm birth by the under 37 definition, but it moves delivery later? Imagine delivery at 28 weeks instead of 26 weeks. Still preterm, still counted as a failure in a binary under 37 endpoint, but the fetus has gained 2 weeks. That can be profoundly meaningful.
This is why time-based outcomes matter. Fonseca did not only report spontaneous delivery before 34 weeks, it also used Kaplan-Meier analysis, with gestational age as the timescale. The hazard ratio for continued pregnancy without spontaneous delivery before 34 weeks was 0.57. That is a time-to-event way of saying the treated group was less likely to deliver spontaneously before the early preterm threshold across the observed time period. The PREGNANT trial also used survival-style thinking and a clinically early endpoint, preterm birth before 33 weeks. Its primary result was 8.9% with vaginal progesterone versus 16.1% with placebo. That is a threshold endpoint, but it is a threshold chosen closer to the severe preterm problem than 37 weeks. The Romero 2018 individual patient data meta-analysis is especially useful because it gives us both kinds of language. It reported fewer births before 33 weeks, 13.1% with vaginal progesterone versus 21.9% with placebo. Relative risk 0.62. It also reported that mean gestational age at delivery was 0.74 weeks higher in the progesterone group. 0.74 weeks is about 5 days.
Do not dismiss that because it is less than a week. A mean difference is an average across a population. Some patients may gain little, some may gain more. The result tells us that gestational age at delivery shifted later. It answers a question that a binary endpoint cannot fully answer. Did the pregnancy last longer? Late initiation studies make this even more important. If a cervix is first found short after 24 weeks, the question is often not only, can we prevent birth before 37 weeks? The question is, can we gain time from diagnosis to delivery? If the patient is diagnosed at 29 weeks, days matter. If treatment does not move the diagnosis to delivery interval, then its clinical value becomes harder to defend. Dominski's 2026 study directly addresses this. In the matched analysis of women diagnosed after 24 weeks with no prior preterm birth, the interval from diagnosis to delivery was 48.6 days with vaginal progesterone and 49.5 days without. That is not a signal of prolongation. The 2026 American Journal of Obstetrics and Gynecology Maternal Fetal Medicine abstract also used time to delivery analysis. Kaplan-Meier analysis showed no difference, with a log-rank p-value of 0.60. The Cox hazard ratio was 1.28, with a 95% confidence interval from 0.65 to 2.54. Again, no clear evidence of time gained. This is the endpoint discipline the course requires. When a paper says the primary outcome was spontaneous preterm birth before 37 weeks, hear that as one choice among many. Ask whether earlier thresholds were measured. Ask whether neonatal outcomes changed. Ask whether gestational age at delivery shifted. Ask whether diagnosis to delivery interval changed. Ask whether the endpoint included indicated deliveries or only spontaneous ones. Endpoint choice is not a technicality. It is a statement of what the investigators considered success. This also changes counseling. If a patient asks, "Will this prevent preterm birth?" the scientifically honest answer may be, "The best evidence in patients like you shows a reduction in birth before a specific early threshold." Or, "The evidence does not show that starting this medication now prolongs pregnancy." Or, "The trial reduced a birth threshold but was not powered to prove neonatal morbidity reduction." That is more careful than saying yes or no. It is also more useful. Store the endpoint hierarchy. Under 37 weeks tells us term versus preterm, but it is broad. Under 34 and under 33 weeks are more directly connected to early preterm prevention trials. Under 28 weeks captures extreme prematurity. Gestational age at delivery and diagnosis to delivery interval tell us about time gained. Neonatal composite outcomes tell us whether the infant outcome changed, not only whether a threshold was crossed. A good physician should not be satisfied with the phrase, "reduced preterm birth." A good physician asks, which preterm birth? By what definition? And did the fetus gain meaningful time?